So to give our patient perspective, we have Meg Gaines, who's the founder and director of the Interdisciplinary Center for Patient Partnerships at the University of Wisconsin Law School.
I think I'm the only one from anywhere near Iowa where that field of dreams that we seem to be so obsessed with is from. Whenever I'm in this building, I can't resist the opportunity to start with, I'd like to thank the Academy. I'm pretty sure it's the only time I'll ever get to say that, so I think I get it in there. But if I may, I really would like to begin with a thank you, to add my thanks, and to speak presumptively on behalf of the survivor community, to thank and congratulate Julia Rowland, who has provided extraordinary vision, leadership, grit, and that Irish stick-to-itiveness in creating the role of Director of the Office of Cancer Survivorship since 1999. And you might have noticed over time, those of you who work with survivors, that we're pretty picky about having people speak on our behalf. But Julia has been an extraordinary spokesperson for us. So thank you for that. I was in 1994 minding my own business as much as lawyers ever mind our own business. When I was diagnosed summarily with ovarian cancer, the first person in my huge family to have any kind of cancer. At the time, my children were 3 and not quite 6 months, and they are now 26 and almost 24. So to say the story turned out differently than was expected is an understatement. But it kind of got my attention in a way that life-threatening experiences will, and changed what I do. So I now run an interdisciplinary center on the campus of the University of Wisconsin, the schools of law, medicine, nursing, and pharmacy, called the Center for Patient Partnerships, where at the micro level, we train future professionals, law, medicine, nursing, pharmacy, genetic counseling, social work, industrial engineering. Anybody with an interest in the future of healthcare comes together in our center in interdisciplinary teams to do work for patients who call us from anywhere from Tuscaloosa to Istanbul, and we've had patients in all those places, and say, help, I've been diagnosed with something I don't know what to do about, I can't even pronounce it. Or they say, well, I know what I want to do now, this is my second recurrence, but my insurance says it's not, it's not medically necessary, the treatment my doctor and I want to do, or it's experimental, so we work on those issues. And then finally, we work on employment issues with people, because still just about half the people in this country get their insurance through employment. And if you get diagnosed and lose your job, you don't have much insurance. Over the course of the last 17 years, we've taken what we learn in the clinic every day doing these cases and have applied it to help organizations engage patients in redesign. So if you hear me say nothing else today, hear me say that my point is to say we need to learn, all that means, learn to engage patients effectively from the very beginning. It's not if you build it, they will come. We have to get out of the you, they. If we build it, we will come. So we need to do this with you. We need to be fully engaged stakeholders, and I think surveys are better than nothing, but not just survey takers and not after the fact. So that's, if you hear nothing else, please hear me say that. Anyway, that's on the meso level. On the macro level, we help engage patients' voices and get the science of patient experience into such important things as reimbursement through HCAHPS and other. We designed the first qualitative questions going into the HCAHPS, assuming that anything goes into the HCAHPS in the next few years, but we won't go there. So I have a few kind of messages that I wanted to reflect on in looking at the work from yesterday and today. One, as I already said, and I'll say it 100 times, patients must be effectively engaged in our own care. This word delivery, I really wish we could stop using the word delivery, because UPS is in the delivery business and I don't even have to be home when it happens. And so I think we really need to move as thought leaders into concepts of co-creation into really, this is so old, but into nothing about us without us. I mean, still 25 years later, we're doing a lot about us without us. And there are plenty of us that are capable and interested in being engaged in this, and plenty of us who donate a huge amount of time. You heard it from people yesterday and today doing this. So please, we're not, scientists aren't experts at engaging patients. So I think oftentimes clinicians and scientists hesitate to do it because they don't know how, because they're not experts. But we can learn that together. So at the patient's preference level, but let's not assume that we really mean whatever you say, doctor, when we say whatever you say, doctor. What we mean is, I don't want to look or seem stupid or alienate you in some way. My oncologist needs to learn every bit as much about me as she knows about my diagnosis. That's Sir William Osler, who said it's not nearly so important what disease the patient has as what patient has the disease. This has been around a long time. And I need to learn about my diagnosis and about my oncologist and primary care doc and nurse practitioner and everyone on the team. Only when we know and trust each other can we have a true partnership during and after cancer treatment, and that takes time. And survivorship care plans are a way to document what we both understand and to get on the same page and to make sure that my primary care provider is returned to the A team, where she or he has been temporarily out in the minor leagues while I've been engaged in other stuff. 3 points: diversity and silos. Good news, bad news. Our healthcare system is a complex, often nonsensical non-system, which is problematic for sharing what is known among clinicians and patients and for framing guidelines. Electronic medical records are potentially one giant meta-clinical trial. If only they weren't proprietary. Can you imagine how much information is in there about what works and what doesn't, about who's employed and who isn't, about who wants to be working and who doesn't? What could be in there and what we could use. So we need to develop the will to make that happen. Survivorship care plans vary widely, as we've heard today, right? That's good for creativity. It's kind of not as good for shared learning. So you can hear, I was just listening to David talk about, if we could get this kind of crazy bunch of hooligans playing together, we could actually know what works and what doesn't. It seems there may be more efficient ways to build effective survivorship care plans, but we must capture the patient's experience research and share our own research and what we learn from our mistakes. So I'm thinking, what about a virtual community of survivorship care planners who say, here's our research, here's what we know, here's what we learned, here's our reflections. Again, engaging patients in it. So, and also, couldn't we create, as you were talking about, a virtual asynchronous focus group so we can ask patients, wide and deep? Why not? I mean, patients do this all the time. And to do it in a collective way would be, I think, exciting. The second thing, and this is, I'm grateful this has been said this morning a couple of times, survivorship care plans are an important decisional tool, a conversation assist. They're facilitators, but they are not the focus of care. The focus of care remains the relationships. If you look at the research done on what patients want, what's important to patients, they will always tell you the same thing, which is, I want to have a relationship with the people who care about me. And that, I think, remains true whether it's in treatment, in diagnosis and treatment, or post-treatment survivorship care. We mustn't become so enamored of the forest or the slickness of the plan that we forget the trees, and that the value of the plan occurs in creating it together, in my becoming enfranchised, if I haven't already been, as a full player. And then if smoking cessation is desirable, or exercise or nutrition, right, it's not that I'm pleasing mommy or daddy. It's that I'm actually choosing to exercise or quit smoking because I have agency. But if something's delivered to me and told to me, I lose agency. It's anybody who's ever raised children knows about that transition and how important it is to make that. And I think healthcare, the sort of meta culture of healthcare needs to change to facilitate agency because it's not working this way. we also have to have those honest, difficult conversations. I wish I had a nickel for every cancer patient who said, says to me, I said to my oncologist, how come all of a sudden you don't scan or blood test me when just last week you've measured every single output of milliliter of everything that came out of my body? And it's because oncologists or whoever's dealing with these folks are not excited, understandably, to say, look, it doesn't matter when we detect your recurrence. We don't have an arsenal that makes it matter when we detect it. So the fact of the matter is that your symptoms are good enough for us right now, given that what we have to offer. That's a hard thing to say to me, but if you don't say it to me, I know you're hiding something. And once I know you're hiding something, because I wish I had a nickel for every patient who goes, how come all of a sudden she's not talking to me? All of a sudden he just says, well, I don't know, whatever, if your back hurts, let me know, that kind of thing. If I don't trust you, the plan is useless. Behold the wisdom of the shoe industry. Who wouldn't dream of producing a line of shoes that haven't been vetted by the men and women who are going to wear them next year or not, right? And yet we produce survivorship care plan after treatment protocol, after build cancer center after cancer center, without ever asking the users. In some cases that means clinicians, but in many cases it also means patients. And we just don't ask. What would this look like? Would it be important to have natural light here? Would it be important to include this in the survivorship care plan? Instead, we keep kind of going, as David was talking about, kind of keep going back and saying, well, let's try this then. Well, let's try this then. Well, let's try this then, without asking people who are going to be using them, what should we try? And I loved, Dr. O'Rourke, I loved your sort of talking about how, well, we went with this plan, and then we went with this plan, and then we went with this plan, and then it turns out we went with just this one pager because it's not about the plan. I mean, it's about the plan, but it's not about the document. It's about the relationship and arriving at the relationship, and it's about having a willing co-creator who's actually going to view the plan as a compact, a covenant. There's my job in this plan. There's my piece of this plan that I need to take responsibility for. And that's really important, I think. And again, the shoe industry figured this out a long time ago. From effective surveys, I mean, instead of saying on a scale of 1 to 7, my survivorship care plan is what, right? Instead of that, saying, what are 3 ways this plan could be better? And what are 3 ways it really works well? Give patients voices. Let us use our voices. And I think the benefit will be enormous. Again, I loved it when you said there wasn't a good survey, so we built one. I mean, I think that's really important, but build it with patients, because patients can help. Patients who think about this can really help. Think about creating a virtual survivor consulting team. We could have one in 15 minutes, and you could all have a virtual survivor consulting team. Tap into the rapidly evolving science of patient engagement, and there are, if you're not familiar, there are lots of wonderful tools to help. I think David probably pointed out some of them, but the HIP Exchange is the one I know of. It's from the Institute for Clinical and Translational Research at the University of Wisconsin. There's lots of free tools on there for how to engage patients in research, how to engage them in organization and system redesign, how to engage them in all kinds of things. So I encourage you to go in there. And finally, thank you. Thank you for your commitment to this work, for caring as you do, for abiding with us when our fears seize the upper hand, for facing your own mortality so you don't need to change the subject when we're facing ours, for the compassion you show even when we're angry, hurt, and prickly, and you seem like the safest person to give it to, for holding up hope when our arms need a rest, for seeing our wisdom grow even as we get quieter, for falling in love with us as we fall for you, and for joining with us in partnerships that make the impossible somehow possible. Thank you.